I'm going to try to talk about two blocks of information. First, I'm going to use the virus and what we know about screening for virus in order to cover some basic information about how we do screening tests. Sensitivity, specificity, positive, negative, predictive value, and walk through some of the implications of those, especially regarding the spread of disease and prevalence, and talk about how we should be doing our screening. Second, I want to then pivot and talk about some ethical issues regarding dealing with the coronavirus, especially in terms of treatments, who should get treatments, how we should decide whether or not treatments are indeed effective. I will try to present what I know as fact. I'm going to use information that's available to me. If I give you opinion, I will label it as opinion. But both of these things are issues that, although the coronavirus per se will not be on the exam in the next several months, they will prepare you for content that will be on the exam over the next several months. So, screening test, it's all about, we have some reality out there, but we can't see reality directly. We don't have any magic godlike way to get a sense of, for example, who has or who doesn't have disease. In order to get a sense of who has or doesn't have disease, we develop a screening or diagnostic test. The test classifies people as having positive test or not having negative test, the disease in question. Now, once you realize we have a reality, and then once you realize we have a test, there's an obvious question, namely, how good a job does the test do? The fundamental issue here is the test is not always right. If the tests were always right, life in medicine would be much easier, but tests are not always right. One of the ways to look at the test being right or not right is to construct, as we've done here, a simple 2x2 table. This 2x2 table looks at testing versus disease, no disease. And let me just take a moment to walk through the features of the 2x2 table here. I'm going to label the cells so you know what it is I'm talking about and so you get familiar with these terms going forward. Here we have people that test positive who actually have the disease. Here we have people that test negative who actually do not have the disease. Right. That's what most people start focusing on when they think about screening tests. It's not the way to begin thinking about screening tests. You begin with the screening test, think about what you know. All you know from your screening test is a classification provided by the test, either positive or negative. Everyone in the top row here is a positive. Why? Because it's what they got on the test. Everyone in the bottom row here is a negative. Why? It's what they got on the test. Start with what you know. The test, the diagnostic or screening test, gives you results, positive or negative. I remind you that positive is not a good thing. It means you have the disease. And negative is not a bad thing. It means we think you're disease-free. Once we've decided who's positive or negative, now we want to hit the question of how good is the test? How good a match do we have between what the test says and actual reality? Well, we do that by looking at the agreement between the test and disease. So here we have positive with disease. Well, that's an agreement, so we call that true. Here we have negative with no disease. That's agreement, we call that true. The mismatches, the non-agreement, well, those are false. And now we have our cells labeled with their real names. True positive, true negative, false positive, false negative. If you dealt with screening tests by the old ABCD method, please never do that again. It's adding a layer of complexity that is not helpful and not illuminating here. Okay, please notice, before we leave this, as a basic review, that we also have something called marginals. Marginals are the sum of the rows and the sum of the columns. Please notice we also have another remaining important figure, which is the total for the table. Using this table and the information it provides, we may then calculate important things which help us get a sense of how good our test is, what our test can and cannot give us. If we're talking about sensitivity, as a quick review, all we're focusing on are the disease people. Remembering the basic rule is trues on top divided by everything. Trues on top divided by everything. In this case, true positive divided by all the disease people is sensitivity. Specificity. Specificity, well, it's still trues on top divided by everything. In this case, true negatives divided by false positives plus true negatives, or specificity, we're talking about true negatives divided by all the healthy people. Please notice, this is important for our discussion, everybody in the calculation for sensitivity is a disease person. What is sensitivity? It's about detecting disease. What is specificity? It's about identifying healthy people. Notice these are two separate, indeed, independent things. It's possible to have very high sensitivity and very high specificity, or really good sensitivity and really terrible specificity. These are two separate issues here. Clinically, more important to you probably, is positive and negative predictive value. You notice that sensitivity and specificity are column calculations. You notice that positive and negative predictive value are row calculations. But positive predictive value shares the exact same rule as does negative predictive value. Trues on top, divide by everything. Positive predictive value is the true positives divided by all the positives. Negative predictive value is the true negatives divided by all the negatives. Notice sensitivity and specificity and positive and negative predictive value are related in that they share the same table, but they're absolutely not the same thing. We sometimes talk about sensitivity and specificity as the, well, pre-test probabilities. This is what you use when you're selecting the test you're going to run. Positive and negative predictive value, we talk about those as post-test probabilities. This is what you care about clinically when we're interpreting the results of the test we have. Let's do that again. Sensitivity and specificity, that's for test selection. Positive and negative predictive value, that's for test interpretation. Again, these two for test selection, these two for test interpretation. Sensitivity is about disease only, remember. Specificity is about healthy only, remember. Positive predictive value is about how believable is a positive test. Negative predictive value is about how believable is a negative test. From what I read, basic screening test, and there's some variation, but basic screening test for COVID has a sensitivity of 75% and a specificity is very high. I'm going to call it 99%. Sensitivity, 75%, specificity, 99%. Okay, now, since sensitivity is linked to negative predictive value and specificity is linked to positive predicted value, that means that we have a highly specific test that gives us, in general, pretty good positive predictive value. All of that said, I remind you of a key issue. Predictive value, positive and negative predictive value, is heavily related to prevalence. Let's look at a simple 2x2 table then, where we have 2% prevalence. Prevalence, I remind you, is always found in the marginals of the table. For simplicity's sake, I'm using round numbers here. We have 1,000 people that I'm talking about looking at in screening here. Prevalence is 2%. That means disease people out of the total will be 20. 20 is 2% of 1,000. Since sensitivity is 75%, that means the true positives must be 75% of 20 or 15, with the false negatives being 5%. Since specificity is 99%, we have the true negatives at 970 out of the 980, with only 1% left over here, which is roughly 10. Okay, so the table thus laid out here, well, you can see that our positive predictive value is not really good. It's true positive divided by true positives plus false positive, which I remind you, of course, is 25, and we end up with 60%. Negative predictive value, though, is actually pretty darn good. Negative predictive value, we have 970 divided by 975, which gives us an answer of, well, 60% for positive predictive value and 99.5% for negative predictive value. What I just tried to show you is when prevalence of disease is low, the positive predictive value of this test is not really good. That means when prevalence of disease is low, if I think I found someone who has COVID-19, I'm wrong 40% of the time, right? Because remember, tests are not perfect. Tests have properties that make them better or worse. The test we use, screen for COVID, 75% sensitivity, 99% specificity, and at low prevalence, we don't get really good positive predictive value at all. What we do get is really good negative predictive value. That means at low prevalence, the test is really good at telling me who doesn't have the disease, but not so good at telling me who does have the disease. Take that in. That's the key important point here. At low prevalence, we have not really good positive predictive value, but we have really good negative predictive value. Okay, that's when we have prevalence of 2%. What if we have prevalence of 20%? With prevalence of 20%, well, then we can redo our table, same base as before. We can redo our table now using 20%. Remember, prevalence is in the marginals, and so 200 diseased people out of the total gives me 20%. 75% of that is 150, and from the 800 we have here, then 99% of that would be 792. You can fill in the rest of the numbers by simple subtraction. At 20% prevalence, using this data, you can see that positive predictive value has now jacked up to 95%, and negative predictive value is now gone down a little bit to 94.1%. Now, the basic principle here, in case you forgot, I remind you of, as prevalence increases, positive predictive value increases. As prevalence decreases, positive predictive value decreases. If I have two populations, one which has 50% prevalence and one which has 1 out of 1 million people with the disease. If I screen both populations and get a positive for both populations, which positive is most likely to be true? The 50% prevalence. Why? Because there's an awful lot of people in that group with disease, and so when I say I have a diseased person, it's likely to be the case, right? As prevalence increases, positive predictive value increases. You can see that as we use our test in a higher prevalence population, now the positive predictive value becomes useful. But also notice, even with 20% prevalence, we got 5% false positives. That is 5% of people that I say have the disease don't actually have the disease. You also notice as prevalence increases, my negative predictive value goes down, because now that more people have the disease, when I say you're disease free, it's less likely to be true. Let's keep the same thinking going as we move ourselves to 50% prevalence. At 50% prevalence, now here we are out of 1,000 once again. Prevalence is in the marginal, so 50% prevalence, 500 and 500. Now we have 375 as 75% of 500, and we have 495 as 99% of 500. Well, using the numbers from this table, you can now see that positive predictive value has rocketed upward almost 99%, and negative predictive value has fallen to about 80%. Once again, as prevalence increases, positive predictive value increases. As prevalence decreases, positive predictive value decreases. Remember, positive predictive value and prevalence are proportional. Negative predictive value and prevalence are inverse. So what we just rehearsed is when we're using a test in a population that has higher prevalence versus lower prevalence, we're getting different confidence in our results, right? That means when you're using the test in an area that has not many cases, your positive predictive value is actually pretty stinky. When you're using your test in an area that has a lot of cases, your positive predictive value is actually much, much better going forward. Okay, so what I've just said, as we have prevalence going up, we find changes increasing for positive predictive value and decreasing for negative predictive value. What's the point here? Well, at low prevalence, test is good for negative predictive value. At high prevalence, it's much better for positive predictive value. With all this in mind, let's ask then a basic technical question about how we should deploy our testing. Here we have just an idealized image, talking about different groups in the population. We have people that are symptomatic, exposed, not symptomatic, at risk, and then the general population. As we get into the systematic group, that is going to be higher prevalence, right? It's going to be much higher prevalence. And as we're in the general population, that's going to be lower prevalence. So now the question is, who should we screen? Well, when you're screening the symptomatic group with high prevalence, we're going to have a really good positive predictive value. If we screen the general population, we're going to have a low positive predictive value. On the other hand, we screen the symptomatic people, we're going to have a really poor negative predictive value. And when we screen the general population, we're going to have a great negative predictive value, right? The prevalence of the group you're screening changes the confidence you have with the results of the screening. I remind you that what we tend to do is first screen the symptomatic people. And when we screen them to see if they have the disease, we're getting pretty good answer when they do have the disease. There's some people that say we should do general population screening, screen everyone in the population to see who has the disease. Well, you see the problem with that. Once you screen the general population, we're going to tell an awful lot of people they have the disease who actually don't have the disease. Because once we go to lower prevalence, we're going to get a whole lot more false positives. The issue then is believability of the results from your COVID test has a lot to do with the underlying prevalence in the population. So clinically exposed people get much higher positive predictive value, general population much higher negative predictive value. In other words, when we're screening the general population, if we get a negative, you don't have COVID, we can probably believe that. A positive, we don't know. Maybe yes, maybe no. If we're screening in a hospital care setting, symptomatic patients, then when we tell you that you have COVID, you probably do. When I tell you don't have COVID, well, we're going to be wrong some of the time. And there's no way to, well, fix this because the believability of the result changes rather dramatically with the underlying population prevalence here, right? Okay. The whole point is to get you to realize we're talking about the number of cases. We're talking about the certainty of the number of cases we have. That's going to change a lot because we first start off by screening the symptomatic people. And then as we begin to screen different parts of the population, the number of cases you find is going to be less and less and less accurate as we're going forward. I remind you, though, if we only screen symptomatic people and we decide the number of cases we have based on that, we've missed all these cases that are out here in the other groups in the population. Okay, again, the point I'm trying to get you to realize here is the believability of the screening test, positive, negative predictive value, varies based on the underlying prevalence, which is in turn based on the kind of people that we're testing. When we limit our testing to symptomatic people, positive predictive value is high. Everyone you think has a disease probably does. Once you change your testing out in the general population, positive predictive value becomes low. What we can favor and should focus on is negative predictive value. Trying to get you to understand the basic issues and utility of screening in this general changing population. Next, I'm going to leave behind the epidemiology issue, and I'm going to talk about some ethical issues regarding COVID. Issues regarding COVID and treatment makes a really good laboratory to talk about some core ethical issues. So let's start off talking about the use of unproven drugs. Hey, I've heard that hydroxychloroquine can be really useful. A friend told me, I read a doctor that told me this is good. Can I prescribe this for COVID-19 patients? Well, first thing that happens when everyone starts to talk about this drug is people in the general population go out and take the drug for prophylaxis, which is not a good idea. Why is it not a good idea? Because there's no evidence it provides prophylaxis. Let's do that again. No evidence it provides prophylaxis. Yet we're seeing a lot of physicians writing prescriptions for patients because they want this drug for prophylaxis. You say no to that. Why? It's not helping them. And there are some side effects here that need to be managed. But my patient wants the drug. Let's review how this works. Medicine is not, I will do whatever the patient asks for. Medicine is, you, the expert, lay out the menu of options, and then the patient chooses from the options you provide. If patient wants hydroxychloroquine for prophylaxis, no, it's not on the menu. It shouldn't happen. The Federal Drug Administration just arrested a doctor out in San Diego who imported huge quantities of hydroxychloroquine and was giving them out by the internet and other methods to people who wanted to take this drug because they don't want to get COVID-19. And yeah, that's really a con job, terrible medicine. And yes, he should be arrested and lose his license. But some people argue, what's the harm? I mean, we have some patients who are really in extremis. We should give them whatever we think might work. Well, I appreciate you focusing on finding something that works, but that's only half the balance sheet. Hydroxychloroquine has been linked to cardiac issues, and by some things I've read, 10 to 11% of patients. And in some studies in Sweden and France, seizures in patients. Every drug has side effects. The idea that this drug has been approved doesn't mean it's side effect free. Every drug has side effects. The other problem we have ethically, large-scale prescriptions takes away the supply of the drug for people that need it. In my social media feed, I hear from person after person who has lupus, arthritis, and they can't get their drug. This is what they need, and they can't get it because all these people out there taking it for prophylaxis against COVID-19, and it doesn't provide prophylaxis against COVID-19. Wait a minute. Why don't we just give it to people because maybe it will be helpful, right? Forget prophylaxis. Let's just give it to patients who are COVID positive because maybe it will be helpful. And shouldn't we as doctors try to help people? No, you took an oath that said, first do no harm. It didn't say, try it, see what happens. It said, first do no harm. Basic principle. Medicine is not about being right. You won't be right all the time. It's about choosing your error. And so, which error would you rather make? Would you rather give the drug when it doesn't help and might cause harm, or not give the drug when it might be helpful? Well, you don't get to decide that. It's been decided for you. First, do no harm. There's nothing in the 1,000+ years of the practice of medicine that's 2,000 years actually, that says, let's try and see if this works. It's first, do no harm. We favor in medicine the error of doing nothing over the error of doing something harmful. Period. It is the core principle of medical practice. First, do no harm. But I've seen videos where doctors describe hydroxychloroquine working for their patients. Isn't that good evidence that this is a helpful patient? Can we proceed if the patient agrees to this? If it's a patient where you have reason to believe the drug will be helpful, yes. Now the key question, do you have reason to believe the drug will be helpful? How many patients with influenza come to the doctor and want an antibiotic? Come on, a lot, right? Do we give patients with influenza antibiotics? Not unless they have a secondary bacterial infection. We don't simply do what the patients ask. We do what's medically indicated, and then the patient has to consent to that, right? If you're going to tell me that some doctors practice bad medicine, I'm older than most of you. I know this better than you do. But our job here is talk about what the standards of practice should be. Certainly for when you're answering your exam questions, but hopefully when you're actually in practice. Look, I've seen the videos too, where doctors say, I gave this to my patient, and well, when I gave this to my patient, the patient got well, right? But testimonials are not evidence. And by the way, the testimonials you see are about treating patients in extremis, none about giving it to patients with mild symptoms or for prophylaxis. There is zero evidence for prophylaxis or treating mild symptoms. I mean zero, not even testimonial. So let's put that aside. There's no evidence for efficacy for prophylaxis or treating mild symptoms. But you do find some doctors saying, I had patients, they were in the ICU, I gave them hydroxychloroquine, and they got better. Wow, that's really neat to hear. But testimonials are not scientific evidence. Think with all the people that, well, I have this weight loss program I went on. Look how much weight I lost. Does that mean most people lose weight on the program? You know the data says no. Or this nutritional supplement keeps me healthy. Do we have data that show that? No. Testimonials are not evidence. They're anecdotal. Testimonials are a selection of supportive cases where you ignore the non-supportive cases, called confirmation bias. Testimonials accent positive aspects and ignore the risks. Testimonials are not evidence. What's the problem with relying on testimonials? I had a friend who said he gave his patients this and it works. It's because you don't know what would have happened if you didn't do the intervention. Unless you have a comparison group, unless you have a control group, you don't know if there's benefit. There's an old story, Indian story, where a man is walking around the village. He has two sticks and he's vigorously hitting them together. And a visitor of the village says, what are you doing? He says, I hit these sticks together and it keeps tigers out of the village. And the man said, well, we've checked and there's no tigers here. The tigers are gone. There are no tigers at all here. And the man said, see how well this works? That's a testimonial. Saying, I did this and got this outcome. You don't know whether it was chance. You don't know whether it was superstition. You don't know. You need research so we can practice medicine where we have benefit and we're sure about the benefit. The reason why we do research is to make medicine evidence-based, so it's not simply a guess. At this point, the summary of the available data, most robust trials say there's some strong, troublesome side effects and, if best, limited efficacy for hydroxychloroquine. I would love to discover that this drug works. I think it'd be wonderful if hydroxychloroquine helped everybody not get the disease and be freed from the disease when they have it. But the evidence isn't there. You don't get to practice medicine by wish. You practice medicine by evidence. You don't get to be dragged down to the superstitious level of your patients. Your job is to insert the evidence of science into the conversation. It is indeed your job and is the ethical requirement. Consent is required. You can't just give the drug because you think it might be helpful. You should not prescribe hydroxychloroquine unless you can find evidence I'm missing for efficacy relative to side effects. No, right? Unless you can find evidence I'm missing. And again, please notice I'm trying to have some humility here. I could be, missing something that some of you know, but I have looked pretty carefully and I don't see any evidence. They've shut down some clinical trials in Sweden and in France because of the negative side effects. And even when the studies show benefit, there are a few small studies show benefit, the benefit is not really big. It's one of the statistically significant but not clinically useful kind of thing. Let me push on to another point. There's a doctor in Texas, had patients in a nursing care facility. This is where elderly patients go when they need more care. A whole lot of the patients got COVID-19. So the doctor said, well, I'm going to give them hydroxychloroquine and I'm going to do this quickly and I'm not going to tell the patients or their family. Okay, this is so wrong. This is another doctor that needs to lose his license. Informed consent is always required. Let me remind you how informed consent works. You inform and the patient consents. You must inform and then the patient must consent. If the patient consents without information, no informed consent. If you inform the patient doesn't say yes, there is no informed consent. You present the menu, the patient selects the menu you provide. Now, yes, patients get to accept risk. Absolutely, because every medical treatment involves risk. And bluntly, the patient must be clear on those risks. Coming in and telling them the good things and not the bad things that could happen means there's no informed consent. There are 5 things that must be put in place for informed consent to be true, and one of them is you have to tell them the bad as well as the good. If there's not appropriate research, you have no information to provide. I remind you, it's not your job as a doctor to do what you think is best. The first thing you do as a doctor is you get informed consent from the patient. Direct communication from the patient when they're fully informed. Okay, what if you can't talk to the patient? Then you have to talk about to the people representing the patient's wishes, family, friend, somebody specified in a document or a reasonable person, right? And if you can't talk to anybody, then you use the best interest standard. But here's the kicker. You don't use the best interest standard first, use it last. The doctor in Texas said, I'm going to act for the benefit of the patient. Yeah, that's not the rule. There's no ethical rule that says you should do whatever you think is best for your patient. It's you lay out the information, the patient decides. Then that can't happen. You talk to people that can help you understand the patient's wishes. Note, I remind you all, I hope you all know this, family doesn't make decisions for family members. They simply help you understand that family member's wishes. If I go into a coma and you're trying to decide how to treat me, you don't say to my wife, we need you to decide what to do. You can say to my wife, what do you think Steve would want done? And then you only use the best interest standard when we have no other standard to use. Best interest standard, I remind you, is a rational standard. You weigh the benefits and the burdens and make a rational decision. Think about a jury where you're weighing the evidence and then deciding based on the good and the bad together, what's the most rational thing to do. If you think the benefits are high and the burdens are few, absolutely you ought to do that. If you think the burdens are high and the benefits are few, you should avoid doing that. What if you think the burdens are low and the benefit is great, but the patient says no? That's easy. It's no, because the patient is the decision maker, not the doctor. We fall so often into the habit of mind that I'm going to give you this. I'm going to tell you what's best. That's not the way it works at all. If you answer any questions on any of the USMLEs 1 through 3 by saying the doctor should do what's best, you just got the question wrong. Remember, this idea of the best interest standard is the last rule that we use, not the first. The rule is not do what you think is good for the patient. It's do what the informed patient gave you permission to do. I cannot stress that enough. And looking at treatments, talking about what we're going to do with patients with COVID in place is an excellent place to review this general principle. So hydroxychloroquine doesn't look like it has strong efficacy relative to side effects. Okay, but you're watching it all. Published information just in the last several days, a study in the University of Chicago showed some good results for remdesivir, an antiviral agent. The results are very encouraging. Most of the patients in the study recovered and were discharged. Mortality rate for these very sick individuals is only about 2%, which is stunningly good. Very encouraging, but, and I cannot stress again the but, there is no control group. You don't know what would happen to these patients if they hadn't had the drug at all. Sorry, you don't know. Looks good, we just don't know. And details matter. When they selected people for the study, they selected severely ill patients, but excluded patients requiring mechanical ventilation and those with multiple organ failure, including kidney or liver impairment, patients that often are the most at risk of dying. So that left us in the severe group with patients who probably had a better chance of recovery. You see the problem here? Now, I still think the study is positive and encouraging. I don't think there's any way the jury is in for this one at all, but we need to wait for the results of a good study. And there's several excellent studies in place and running as we speak. Also, just this morning is a non-peer-reviewed article out looking at remdesivir in monkeys, where the 6 monkeys that got the drug after infection showed few or great reduction in symptoms, whereas the 6 monkeys who did not get the drug showed the usual course of respiratory problems we associate with COVID-19. So what do I want you to take from this? I want you to not hear me as telling you definitively one way or the other about this drug or that drug. I want you to hear me as stressing these things must be done in a certain way with a certain process that gives us information we can trust, believe, where we can have good outcome. Grabbing a drug because somebody publicizes this drug as effective, you got to listen to the experts. You swore to do no harm first. You did not swear to give something a flyer to see what happens, and the ethics here are very clear. Do we want to have, as quick as we can, pharmacology that deals with COVID-19? Absolutely yes. And let's also stress the other problem with hydroxychloroquine. Once you find something that you think is something you're going to use, you stop looking for other things. The other problem with hydroxychloroquine is everyone says this is it, and they stop looking. Like in the cop shows. Once you think this guy killed him, you stop looking at all the other suspects, and maybe the murderer gets away. You follow what I'm saying here? The reason why we have science is so we don't screw up. Yes, we're going to make errors, but we make many fewer errors, and we get better results for our patients. Consent is required. Information must be given before consent, and then the patient gets to say yes or no based on the data-driven information we can give them. Okay, with that, ladies and gentlemen, that ends my point about the ethical issues involved here. Okay, thank you very much, ladies and gentlemen.